I hope y'all can see the screen. Can y'all see the screen? Can you guys see the screen, the presentation? All right, okay. So I will start. So now, like I said, I'm doing obstructive jaundice. So before we do anything, we have to really know the anatomy a little bit. So this is the anatomy of the extrahepatic biliary system. So what's important here is the duct system here. So you just need to know this. So you have the right and left hepatic ducts, which are coming from the liver, and they will join to form the common hepatic duct. And then you have the gallbladder, which will join with the cystic duct to form the common bile duct, the CBD. So these will all go, and this is where the ampulla of Vata is, right? So this is where you will find your periampular carcinomas as well. So we will discuss that later. But what you need to know is this is where the ampulla is. So like you can see, it consists or it involves the duodenum, the pancreatic duct, as well as the CBD. So that's important here. And now just the pancreas here. So obviously this is the head, tail, and the pancreatic duct. So this is basic anatomy of the, hold on a second, let's put on noise. Okay, sorry about that. So this is the basic anatomy of the extrahepatic biliary system that you need to know. So before we really talk about obstructive jaundice, we need to know about the metabolism of bilirubin. So that's important. So here you can see the metabolism. So when we talk about obstructive jaundice, it's a surgical jaundice. So that's basically this portion, the post-hepatic portion. But you need to know the prehepatic and hepatic as well. So these come under more of medicine jaundice, but for the surgical, you need to understand this as well. So first of all, we start with hemoglobin. The hemoglobin will break down and form heme and globin. So this heme becomes biliverdin and iron, and the biliverdin is converted to bilirubin. So at this stage, it's unconjugated and it's water insoluble. So therefore, this will combine with albumin to travel in the blood. So this is important, okay? You need to know this metabolism well for you to really understand obstructive jaundice and the investigations and the results you will find with the investigations. So the bilirubin, water insoluble, therefore it will combine with a protein, which is albumin, to travel in the blood. So right now is unconjugated. So it will travel in the blood to the liver. So at this point, it becomes a hepatic process. So in the liver, the unconjugated bilirubin will get conjugated. And this is done by an enzyme called UDP, glucuronidase transferase. So just remember this because they can ask you this in a discussion. So it's better if you know this. And so this will form conjugated bilirubin. So the moment it gets conjugated, it becomes water soluble. So it becomes bilirubin glucuronide. So this is secreted into the biliary system. So this is what leaves the liver. So this will leave the liver, enter the biliary system, and finally enter the duodenum. That's how it enters the GI tract. So post-hepatic, that is after the liver, so it will go in the biliary system into the GIT. So in the GIT, it will form the stercobilinogen. This is due to the bacteria that is present in the duodenum. So a portion of the stercobilinogen, or rather majority of it, will be secreted in the feces. However, some of it will enter the extrahepatic circulation and it will be secreted in the urine as urobilinogen. Okay, so what you need to remember is urobilinogen is only produced if there is stercobilinogen. So stercobilinogen is needed here. Okay. Then, so we'll just talk about jaundice. So what is jaundice? Jaundice is a clinical condition which is manifested by the yellowish discoloration of skin, sclera, and mucous membranes. This is due to the excess accumulation of bile pigments within blood. So hyperbilirubinemia and other tissues. So bile pigments can exist as conjugated or unconjugated bilirubin, and the elevation of one or both will give rise to jaundice. So like I said, you need to know the metabolism here to understand at which level the jaundice or the obstruction or the problem is. So jaundice, how do you quantitatively categorize jaundice? So the quantitative value here is the normal level of total bilirubin in the blood is 17, 1 milligram per dl, but 17 millimoles per liter. So a clinically apparent jaundice will be there when the total bilirubin is more than 35 to 40. So basically double. That's what you need to remember. So jaundice is clinically apparent when the total bilirubin level is more than 35 to 40 millimoles per liter. So why do you get icterus? So the scleral elastin has a high affinity for bilirubin. Therefore, it is sensitive. So you will get icterus. So remember, when you're taking your history and your examination, don't say jaundice if there is yellowish discoloration of the eyes. Make sure you say icterus. So what are the mechanisms? So like before we spoke about, the jaundice can be at different levels. So that's basically what we're talking about here. If it's a hemolytic type of jaundice, that is, it's pre-hepatic, that is due to excessive production of bilirubin due to hemolysis or ineffective erythropoiesis. So you will have a pre-hepatic type of jaundice, which is hemolytic jaundice. And this will cause the unconjugated bilirubin to increase because the problem is here. So when the problem is here, the unconjugated fraction will increase. Okay. Then you have a hepatocellular jaundice, that is hepatic portion. So this is due to a problem in the liver. So this is in impaired uptake of hepatocytes, failure of conjugation, impaired secretion of conjugated bilirubin to the biliary system. So those will all cause hepatic jaundice. Then we come to the post-hepatic, which is obstructive jaundice, cholestatic jaundice, surgical jaundice. So these are all the same thing, but the main name that we go by is obstructive jaundice. So this is impairment of the flow of bile in the biliary system. So something in the biliary system will impair the flow, and this will cause obstructive jaundice. So this is what is relevant for surgery. Okay, so for the surgery topic, this is what is relevant. But you need to know these as well because this will help you differentiate in your history. So obstructive jaundice occurs due to the impairment of bile flow subsequent to secretion by the hepatocytes. So that is, the liver secretes, but there is some issue in this area. So the liver is here, they have secreted the bile, but there is some obstruction here leading to obstructive jaundice. So this can be due to intrahepatic or extrahepatic cholestasis. Okay. So obstruction of the extrahepatic biliary tree gives rise to conjugated fraction of bilirubin. Because remember, the conjugation happens in the liver. So when you talk about causes of obstructive jaundice, if you are asked for the causes either in your long case or even in the paper, you need to, it's better if you can categorize it because that shows that you have understood. So when you're categorizing it, you can go within the lumen, that is inside the lumen of the CBD, in the wall, or outside the CBD, outside the wall. So it's an it's a compression from the outside. So in the lumen of the CBD, obviously the commonest one is the common bile duct stones. Okay. Then you have other obstructions that can happen within this lumen. That is, if you have any parasites, biliary parasites, any worms, ascaris, then even liver flukes. So these are what Dulanta sir has mentioned. So please mention these if they ask you what are the causes for intraluminal obstruction. Then you have intramural, that is inside the wall. So here you can have three things that can cause this. Strictures in the wall, cholangiocarcinoma, either distal, proximal or hilar, all three, or polydocus cyst. Now, one thing to note here is, according to Dulanta sir, ERCP is not a cause of stricture. But some surgeons consider ERCP a cause of stricture. So be careful when you say this, especially if you get Dulanta sir for your case. So I would suggest try not to say it. If you really don't have another choice, or if they keep asking you, then you say it, but don't say this first, because Dulanta sir has very specifically said that ERCP doesn't cause it. However, some surgeons believe that strictures are caused by ERCP or post-ERCP. So strictures can be due to instrumentation, even surgery, and due to IBD. This is because of the inflammation. So what happens here is, because of the inflammation caused by IBD, you can have fibrosis, and this can cause a sclerosing cholangitis. Then you have extramural, that is outside the wall. So that's an external compression. So carcinoma of the head of pancreas, periampular carcinoma, chronic pancreatitis, and even enlarged lymph nodes at the porta hepatis. Sorry guys, there was a bit of noise. Okay, so that's basically the causes. So categorize your causes like this. So this is from Dulanta sir's lecture notes. So it's the same thing. I just included it here because it's a bit easier to understand, because he's really explained it here. Okay, and it's in a nice diagrammatic representation. So rare causes, so we've spoken about the causes here, but the rare ones are the polydocus cyst, the sclerosing cholangitis, and Mirici syndrome. So those are rare. Just know that these are rare, but you can mention them as causes like mentioned here. So common bile duct stones, basically cholelithiasis is the most common cause of biliary obstruction. So stones may be secondary calculi formed in the gallbladder. So these can be cholesterol stones or black stones. They can also give rise to stones primarily caused in the CBD. So these are usually brown stones and form in the presence of an infection, stasis of bile, foreign bodies, like if there is a stent, or biliary parasites. So patients classically present with a sudden onset of jaundice. This is due to the stone suddenly falling from the gallbladder to the CBD. So there may be episodes of fluctuation. So what you need to remember is sudden onset of jaundice there can be episodes of fluctuation. Typically, the patient will present with pain, usually right upper quadrant or epigastric kind of pain, which radiates to the back. However, the pain may be absent in some patients, especially the elderly, but this is not the common presentation. So when you talk about stones, you talk about, or rather bile stones, talk about the sudden onset jaundice may have episodes of fluctuation, typically having pain in the right upper quadrant or in the epigastric region, radiating to the back. So the gallbladder is not distended in obstructions due to CBD. This is the Crozier's law. So this is because with gallstones, the gallbladder is chronically inflamed. So when it heals, it will heal with fibrosis. So once there is back pressure, this can't distend a fibrotic gallbladder. So this is a law. You need to know this law to explain this at your long case, mainly even for the paper, they can ask you. So in a patient with obstructive jaundice, a palpable gallbladder, that is a distension of the gallbladder, is unlikely due to the gallstones. Okay, so that's the law here. So if you have a palpable gallbladder, it's unlikely to be due to gallstones, and you need to look for another cause. That's basically what it is. So what is this law? So if the gallbladder is palpable, the cause of jaundice is unlikely to be stones. So you need to consider other causes. But here because here the gallbladder won't be fibrous. Therefore, it will also distend with the rest of the system. So like you can see here, when you have your obstruction, this whole system will get distended. Whereas if you have a fibrous gallbladder, the gallbladder won't be distended, rather only the system will be distended. So there will be edema of the biliary system due to back pressure. Okay, so as the stone forms, it causes fibrosis and scarring. Therefore, the gallbladder doesn't distend even though the other biliary system is dilated. So that is basically your law. But what you need to remember is there are exceptions. So the exceptions to the law is if it's a primary CBD stone. Give me a second. So sorry about the sound noise. Okay, so this is the exception. So that is a primary CBD stone. So that is the stone was formed in the CBD, not in the gallbladder. Therefore, the gallbladder won't be fibrosed. So that is an exception. So when it's not formed in the gallbladder, that chronic inflammation doesn't occur. Therefore, this gallbladder won't be fibrosed. So gallbladder stone, the second reason is gallbladder stone, but the second stone at the gallbladder is causing the acute inflammation. Okay, so that's what I have drawn here in the corner. So this is it's a gallbladder stone that has caused the distension of the system. But there is another stone that has caused an acute cholecystitis of the gallbladder. So there are two stones here. I hope you all understand this. Okay. Then you have something called Mirici syndrome. Mirici syndrome is okay. So Mirici syndrome is an anatomical anomaly. This is where you have a short cystic duct. That is the duct that connects the gallbladder to the CBD. So this is what happens here is one stone will cause an acute cholecystitis. It swells up the gallbladder. Therefore, it's palpable. It now will compress also the other system from outside, causing obstructive jaundice. So that is what I have drawn here at the bottom. Okay. So other exceptions for the law is a cholangiocarcinoma that is above the cystic duct, which won't really dilate the gallbladder. So what happens here is the obstruction is here. So when the obstruction is at this point, again, it will dilate above the obstruction. So the gallbladder will be spared. So this is known as the Klatskin tumor. Or rather, this includes the Klatskin tumor, this concept. Okay. So what is cholangitis? So this is a life-threatening emergency or infection. So this is an ascending kind of infection that results from an infection within the obstructed or poorly draining biliary system. So in patients with CBD stones, coliforms have been identified within the bile in around 80% of cases. So these are for your MCQs. Typically, it presents with a triad of symptoms. So this is what you call the Charcot's triad. So you have pain, jaundice, and fever with or without chills and rigors. So with the Charcot's triad, you also, so again to repeat, it has a deep jaundice, fever with or without chills and rigor, and abdominal pain. Then you have something called the Raynaud's pentad. So the Raynaud's pentad is above all is included. So all three plus altered mental status and hypotension. Then you have another cause of obstructive jaundice, which is carcinoma head of the pancreas. So here the presentation is an insidious onset. It's progressive and usually painless jaundice. So the carcinoma of the head of the pancreas, as it progressively worsens or gets more, it's a progressive type of jaundice and usually painless. There may be loss of appetite or a vague, persistent epigastric or back pain. So these are important points. Loss of appetite and a vague, persistent pain. The gallbladder is usually palpable in this case. So again, it's under, right? So when it obstructs, that system will, including the gallbladder, will get distended because the gallbladder is not fibrosed. Pancreatic cancer have poor prognosis with 5-year survival in the range of 5%. So pancreatic CA has a poor prognosis with 5-year survival in the range of 5%. So these are all Dulanta sir statistics. So these are fine to tell at the exam. Then you have something called periampular carcinoma. Here the carcinoma is within 2 centimeters of the ampulla. So what you need to understand here is periampular carcinoma is in this anatomical diagram. It's here within 2 centimeters. So if you draw a 2 centimeter circle here, it will include duodenal CA, pancreatic head, CA of the head, as well as carcinoma. So it's a second. Okay. So it's a carcinoma within 2 centimeters of the ampulla. So duodenal, cholangiocarcinoma, and pancreatic carcinoma. So these tumors arise on the ampulla aorta and may be duodenal, biliary, or pancreatic in origin. May also present with painless progressive jaundice. However, there are episodes of fluctuation. This is due to necrosis and pressure near the central part of the tumor. So remember that, okay? So what happens here is when you have the carcinoma, so let me just draw this. So you have your duct coming in, then you have your, it's a very bad drawing, but you have your duodenum, your duct, as well as your pancreas, right? So this is where your tumor is. So what happens here is when you have a tumor like this, when the necrosis, so the tumor will get big and it will obstruct. This will cause obstructive jaundice. So you will have icterus and all that. As the tumor necroses, there is a gap that forms here, creating a pathway for the bile to flow again. Therefore, the obstruction is relieved. Then once the obstruction is relieved, the jaundice will settle. But again, the tumor is a growing tumor, right? So it will grow again and cause obstruction again. This is the reason for the fluctuation. So I hope you understood that. If you didn't, tell me, I'll explain that again. So periampular carcinoma may also bleed into the duodenum, giving rise to a classical melena. That is your silvery gray stools. So this silvery gray stools is because you're having obstructive jaundice. You anyway have pale stools. And then you have the slight melena as well. So therefore, you will have a silvery gray stools. The gallbladder is usually palpable in this case as well. So same story, right? So the obstruction is below the level of the gallbladder. So therefore, it will distend the whole system, including the gallbladder, because the gallbladder won't be fibrosed. As most tumors are of duodenal origin, outcome is significantly better than pancreatic adenocarcinoma, with early tumors having 50% 5-year survival rate. So that's an MCQ point. So most tumors are of duodenal origin, and the outcome is better than compared to a pancreatic origin tumor. And early tumors have about a 50% 5-year survival rate. Then you have distal cholangiocarcinoma. So these tumors arise distal to the origin of the common bile duct. Therefore, it will present with a palpable gallbladder, right? Same concept. So presentation and outcome is similar to that of a pancreatic adenocarcinoma. Then you have proximal cholangiocarcinoma. So these tumors arise from the right and left hepatic duct. So it's above the level of the gallbladder. And the common hepatic duct proximal to the insertion of the cystic duct. So you have the right and left hepatic duct, common hepatic duct, and it's proximal to the cystic duct. So therefore, this is above the level of the gallbladder. Therefore, the gallbladder won't distend. So what will distend is the part of the biliary tract above the level of the tumor. So the gallbladder is below, therefore it won't distend. So it won't be palpable. So tumors arising at the confluence of the right and left ducts are known as the hilar cholangiocarcinoma or the Klatskin tumor. So this was an MCQ or an SBR that we got. I'm not sure which one, but so this was a question that we got. So I'm not sure if it was an MCQ or SBR, but the stem was that if there is a Klatskin tumor or hilar cholangiocarcinoma, the gallbladder is not palpable or palpable. So that's the concept. So if you know this can come for an MCQ. So chronic pancreatitis. Chronic pancreatitis is a chronic inflammatory condition, as the name suggests, which may result in the development of a fibrotic inflammatory mass in the pancreatic head. So this may result in, again, obstruction of the biliary tract because the pancreatic head is near the ampulla of Vater. So benign biliary strictures, 80% are iatrogenic, occurring following an open or a laparoscopic cholecystectomy. Okay, so that's what I said. According to Dulanta sir, ERCP, post-ERCP is not a cause of strictures, whereas it's more common with your surgeries. So with your open or laparoscopic cholecystectomy. So the incidence is given here. So as you can see, the incidence is higher with laparoscopic. So injuries may be due to a partial or complete division of the duct or inadvertent clipping, which causes a rise to rapid jaundice, cholangitis, and abdominal pain in immediate post-operative period. Right. So here I have put a star is just to explain what will happen. So there will be a leak or damage to the ducts, which will cause biliary peritonitis. The bile will get absorbed, resulting in jaundice. So that's how you get your jaundice. So the ischemic strictures may occur due to disruption of the blood flow to the bile ducts, which may present even late. So this kind of stricture can present 6 months to 1 year even later, post-operatively. So 20% of the benign strictures occur due to inflammatory causes. So this is the other one. So remember I said you can have lymph nodes at the porta hepatis. So the porta hepatis adenopathy, this is an extrinsic compression. So from the outside to the proximal biliary tree by lymph nodes in the porta hepatis region that can cause obstructive jaundice. So this can happen easily in lymphomas and nodal metastasis from breast CA and gastric carcinoma. Okay, so coming into the history, this is what you basically need to ask in your presenting complaint and your history of presenting complaint. So your cardinal features, that is, if these 4 are present, this patient has obstructive jaundice. They are cardinal features, mainly the pale stools. So you have deep jaundice, dark urine, pale stools, and pruritus. So the deep jaundice is a given. Then you have dark urine. So dark urine is due to the filtration of conjugated bilirubin by the kidneys, which give rise to a characteristic tea-colored urine. Right? Give me a second. Right. Then you have pale stools. That is due to the absence of bile in the stool. This prevents the formation of stercobilin. So the stercobilin is what we need to get our normal color in the stools. So when there is no stercobilin, the stools will be pale. Then you have pruritus. So this is due to the deposition of salts, bile salts in the skin. So this will cause a skin irritation. Therefore, in your history, you need to ask the patient if the patient has disturbed sleep. So these are these little points that you can ask in your history. So because of the pruritus, because of the constant irritation of the skin and itching, the patient can have disturbed sleep. So the first, second, and fourth, that is the deep jaundice, dark urine, and pruritus can be there even in medical jaundice as well. However, for there to be pale stools, this is obstructive jaundice. Okay. Other features are because of the malabsorption of fats, more fats are secreted or excreted in our feces. So when it's excreted in our feces, when there's a lot of fat, you will have floating stools. So that is what you have to ask in the history is, do they find it difficult to flush after using the washroom? So if there is a difficulty to flush, that indicates that there can be steatorrhea because it is because of the high content of fat in the stools. So other features can be due to chronic malabsorption of fat-soluble vitamins. So when there is a fat malabsorption, there is decreased fat levels for the fat-soluble vitamins. So therefore, there will be a decreased absorption of these vitamins as well. So if there's a vitamin K deficiency, you will have a bruising and bleeding tendency. So coagulopathies. Rarely you can have other fat-soluble vitamin deficiencies like vitamin A, which will cause night blindness, vitamin D, which will cause osteomalacia and neuromuscular weaknesses as well. So these are rare, but better to ask in the history. Then after you have asked all these questions, you need to exclude the medical jaundice as well. So here you need to exclude causes of hemolysis and causes of hepatocellular dysfunction. So for liver issues. So family history of blood disorders, exposure to infective agents, any recent drugs and changes in medication, and any history of food ingestion from outside. That is for hepatitis. Okay. Then finally, you need to come to a differential diagnosis. So you need to figure out what is causing the obstructive jaundice. So here the differential diagnosis, you have stone disease. So one thing here is you need to ask painful and history of biliary colic with intermittent jaundice. So again, like I said earlier, absence of pain doesn't rule out gallstones, especially in elderly. So you need to ask them if they have any history of any biliary colic, whether the jaundice is intermittent, and if there is pain. Then carcinoma head of the pancreas, as usual, you have loss of appetite and loss of weight. However, what you need to understand is when you have a carcinoma head of the pancreas, the loss of appetite and the loss of weight will come before the jaundice, because the jaundice will only come when the carcinoma is big enough to obstruct the biliary flow. So loss of appetite and loss of weight appearing before jaundice. Then you have cholangiocarcinoma, where the jaundice will come before the loss of appetite and loss of weight, because this is a carcinoma that is forming within the tract. Okay. Periampular carcinoma, again you will have intermittent jaundice. I explained why. So again, as the necrosis of the tumor happens, the obstruction is relieved and the flow is restored. Therefore, the jaundice will resolve. But as the tumor grows, the obstruction will come again and therefore the jaundice will return. So it will go on like this. So it will be intermittent in nature. Hematemesis, because again there is necrosis of the tumor, and as the tumor necroses, there will be blood released into the GI tract. So you will have hematemesis and melena. So if you have a melena, you will have silvery gray stools. Okay. Then you have chronic pancreatitis. So here you ask for epigastric pain, whether it radiates to the back, whether it's relieved by bending forward, and worsen when lying back. Then you need to exclude biliary strictures. So here you ask for any history of hepatobiliary stones and surgery, and ask if they have had any stones, because like I said, some consultants consider ERCP a cause for stricture. So any interventional therapy that has been done can cause a stricture, any instrumentation that has been passed through. Then any enlarged lymph nodes. So the enlarged lymph nodes, again, you need to ask for any past history of gastric CA or lymphoma or breast CA. So after you have done your differential diagnosis, you need to try and find a cause. So the main things here is gallstones and carcinoma. So for gallstones, you ask about any high cholesterol diets, whether they have hyperlipidemia, whether they have any hemolytic disorders. Then you need to ask for carcinoma, smoking, alcohol, again high fat diet or cholesterol containing food, and family history. Then finally, you come to the last bit of your history of presenting complaint, where you assess the complications that can occur due to the causes of obstructive jaundice. So coagulopathy, we discussed this a bit later, but mainly you have to ask about coagulopathy. So mucosal cutaneous bleeding. This is due to a decrease in fat-soluble vitamin absorption, so vitamin K deficiency mainly, and it is needed for the clotting pathway. So what happens here is when there's a vitamin K deficiency, you will have a coagulopathy. So you have to ask this. Then you need to ask about steatorrhea. So that is bulky, greasy stools that is difficult to flush. Whether they have had cholangitis, any fever and chills in the recent past or in the past, before even if they had stones. Liver failure, again, altered sleep patterns and confusion. And renal failure. So here mainly it's hepatorenal syndrome. So why hepatorenal syndrome happens is due to the decreased liver function, metabolism of nitrous oxide is reduced. So that means it accumulates. So when nitrous oxide accumulates, this is a potent vasodilator. So the splanchnic vessels will get dilated. So when the splanchnic vessels get dilated, the blood pools in the splanchnic vessels. This reduces the renal perfusion. So when the renal perfusion is reduced, obviously the renal function reduces. So the urine output will decrease. So investigations you can do here is you basically check for renal function. So serum creatinine needs to be checked. Then treatment is you need to ensure hydration. So IV fluids are given. If the patient is on any diuretics, you need to withdraw these diuretics. And you need to know what your problem here is splanchnic vasodilation. So you need to give a splanchnic vasoconstrictor like terlipressin. And finally, you need to ask for features of metastasis. So lung, liver, brain, and bone. So I'm sure you all know the questions you ask, but basically for lungs, you need to ask whether they have any shortness of breath, whether they have any other issues like cough, chronic cough, liver, right hypochondrial pain, brain, you ask for any early morning headaches, any features of fitting, if they have ever been admitted for fitting, and bone is intractable back pain, any other, also for now here we anyway talk about jaundice, but for liver you can also ask about jaundice in other cases. Okay, sorry, that slide has been repeated there. Okay, so why do these patients have a coagulopathy and how will you correct it? So a mnemonic that we have been taught is KADE. So vitamin K, vitamin A, vitamin D, and vitamin E. These are the fat-soluble vitamins. So our big problem here is vitamin K. So vitamin K is a fat-soluble vitamin. So in obstructive jaundice, there is obstruction. Therefore, bile salts are now coming into the duodenum. Therefore, there is a decreased level of lipid metabolism from our diet. Decreased lipid absorption means decreased vitamin K levels because these are fat-soluble vitamins. So how you correct it is, we will talk about how we correct it a bit later because there is a slide talking about the issues associated with correcting obstructive jaundice or investigating obstructive jaundice. So examination points are, you have general examination, abdominal examination, and features for chronic liver disease. So these are the main three things that you need to look for in your examination when you are doing your long case. So in your general examination, you look to see whether there is any temperature, whether the patient has fever, and look for signs of pallor because the patient can have anemia due to a carcinoma. Then jaundice, obviously, icterus, you need to check for any icterus and any other, if the patient can genuinely be completely jaundice. So you can check for these, right? So bleeding manifestations, stretch marks due to the pruritus. Then thrombophlebitis can be there due to pancreatic CA. And you need to make sure you check for left supraclavicular lymph nodes or the Virchow's node. Then the abdominal examination, you need to do your full abdominal examination, mainly focusing to see whether the gallbladder is palpable or not. And if you can feel any epigastric mass, which might indicate a carcinoma of the head of the pancreas. So like we spoke about before, palpable gallbladder means that the obstruction is occurring below the origin of the cystic duct. So this may give rise to a clinically palpable gallbladder due to the passive distension from the back pressure. So features of chronic liver disease, you need to just go head to toe. So you can check for parotid enlargements, gynecomastia, if there's any spider nevi, loss of hair. You can ask if you have the privacy, you can check for testicular atrophy, but not really necessary. But make sure you mention some of this, okay? Ecchymotic patches, distension, whether there's any ascites, hepatomegaly, splenomegaly, palmaerythema, and leukonychia. Okay, so although I have categorized this like this, when you're presenting, obviously you will combine these with your general and abdominal examination. So this doesn't go as a separate point. This is just so that it's easier to understand. Okay, so how will you investigate obstructive jaundice? So again, when you talk about investigations for obstructive jaundice, you need to go in some sort of order. So you will first do investigations to confirm your diagnosis. Then you will do investigations to look for a cause for the obstructive jaundice. And finally, to assess any complications. Okay. So here you will do, to confirm your diagnosis, you can do blood investigation is your total bilirubin and your direct bilirubin values. So your total bilirubin and direct bilirubin will give you an idea of the type and the degree of jaundice. Now this point that is highlighted here is what is told by Dumindu sir and what he expects you to know even at the exam. So if the total bilirubin is more than 20 milligrams per DL, this suggests an unfavorable disease. Say this word to word, okay? Because this is what Dumindu sir said, and which he asked us during the appointment as well. If the direct bilirubin is more than 20% of the total bilirubin, this is suggestive of obstructive jaundice. Okay. Then another test you can do is checking the ALP levels, because an increased ALP level is a sensitive indicator for biliary obstruction. This is due to the failure of the excretion of bile. Then in the urine, you can look for urobilinogen. So this will obviously be absent, but the conjugated bilirubin content will be present. Then there's another scan that you can do, which is the HIDA scan. So this is a radioisotopic scan. This will detect the excretion into the biliary tree or system. So looking for a cause, ultrasound scan is the main thing. This is to exclude stones. So you need to mainly think about stones. So a dilated common bile duct more than 6 millimeters or a dilated gallbladder can be seen. You can assess the liver. You can locate the cause of the obstruction. So if it's a stone, if it's a cancer, if it's a periampular carcinoma, cholangiocarcinoma, you can find this from the ultrasound scan. Then the other investigations for causes, ERCP, CT abdomen, CT cholangiogram, MRCP, PTC, endoscopic ultrasound, and cholangioscopy. So these are discussed a bit later. I just listed all of them out here. Then to assess your complications, you can, first is coagulopathy. So you can check the PT-INR as well as check the platelets when you do a full blood count. So PT-INR will be impaired with liver dysfunction and vitamin K related coagulopathies. Then in the liver function, you check for AST/ALT levels and serum albumin levels and gamma GT levels. Then if you're suspecting an infection in your full blood count, your WBC will be elevated and your CRP levels have to be checked. Then again, like I said, you can have anemia. So you have to check your hemoglobin. And finally, we have to check for any hepatorenal syndrome. So here you will check your renal function tests like a serum creatinine, serum electrolytes, and blood urea. And finally, if you are really suspecting a tumor, you can even check your tumor markers. So these are, I have listed out according to confirmation of diagnosis, looking for a cause and assessing complications. But when you're answering, try to not repeat the same investigation. So when you're saying assessing complications, start with full blood count and say, I will check the hemoglobin for anemia, platelets for coagulopathy, and WBC count for any infections. Then next one, you will check for coagulopathies with your platelets. If they look deranged, you might even check your PT-INR to look for any vitamin K related coagulopathies. Then you will do liver function test, kidney function test. And if you really suspect a tumor, you can do a tumor marker. So ultrasound abdomen here, it is the first line radiological investigation in your obstructive jaundice. So it's cheap, easily available, and will guide your next step. So you can identify dilated intra and extrahepatic biliary tree, look for any gallbladder distension, thickening, gallstones, CBD stones, pancreatic masses, and features of chronic pancreatitis. So in your ultrasound scan, if you find a CBD dilatation plus an intrahepatic dilatation, this will indicate a long-standing disease. So key learning points is this is in Dulantha tooth. So diameter of the normal bile duct is about 6 to 7 millimeters. So ultrasound scan visualization of the CBD and pancreas is limited due to bowel gas. So CT scan of the abdomen. So this is the next investigation, especially if a malignant obstruction is present. So if you suspect a malignant obstruction, your next step after your ultrasound scan will be a CECT. So this will help you figure out pancreatic masses, chronic pancreatitis, might show you gallstones, lymph nodes, gallbladder tumors, and other relationship to portal structures, IVC. So any metastasis as well. Then you have your ERCP. So this is a powerful diagnostic and therapeutic tool, and it allows for radiological visualization of the biliary tract following a retrograde injection of contrast into the tree using a side viewing endoscope. So this allows for imaging of the biliary and pancreatic tree, which uses a fluoroscope, that's C-arm. So during the appointment, some groups have got to see like how an ERCP was done. So basically you use a C-arm and get images, and that helps you visualize. So usually now ERCP comes with its complications. So usually you don't do ERCP as a diagnostic tool alone. You don't jump and do it. But if the ultrasound scan shows stones, then you go ahead with an ERCP and take the stone out. So this allows for diagnosis of a multitude of pancreatobiliary conditions, including jaundice. So ERCP is also used to perform a number of interventions, including extraction of stones, biopsies, and insertion of stents. So here, the values I'm talking about are the values told by Dulantha sir. However, Vasantha sir doesn't necessarily agree with the 2 to 5% risk and the less than 1% mortality. So I'm just letting you all know, but this is what Dulantha sir said at the lecture, okay, and even during the appointment. So 2 to 4% risk of post-ERCP pancreatitis is there. So if there's a high risk of post-ERCP pancreatitis, it's better to give a suppository diclofenac sodium, and because this has shown some benefit, right? So because of the 2 to 5 risk only, it is no longer used as a diagnostic only tool. Then the mortality rate is less than 1%, and the mortality is due to, again, pancreatitis, bleeding, and cholangitis. Percutaneous transhepatic cholangiography, that is PTC, is a diagnostic and therapeutic tool. So a radiologic technique where contrast medium is injected into the bile ducts in the liver via a needle inserted under imaging. So you can see this, right? The needle is inserted and the needle injects contrast medium into the right bile duct. So you can see what's happening here. The tumor is here. So if there is a Klatskin tumor, that is here. Okay. Then a needle will also inject contrast medium into the left bile duct also. That can also there. So what you will see is there will be dilated biliary ducts because the contrast can't go because there's a Klatskin tumor. So the scope is inserted. So this is another one. The scope is inserted through the skin into the liver. A lithotripsy catheter disintegrates the large stone. And that's, and a balloon catheter pushes the fragments into the duodenum. So here you can see how that procedure occurs. So then you have your MRCP. So this is basically an MRI, but specific to the biliary tree. So acute anatomical images of the bile duct and the pancreatic duct system can be obtained by an MRCP. So it provides equivalent or superior imaging to ERCP and TTC. So it's non-invasive, but more costly. And it's better if you're suspecting stone disease. If you're suspecting malignancy, CT is better. So these are a few points that you can, the summary points basically. So it's more superior to ERCP, not easily available and expensive, and this is not therapeutic. So even if you do an MRCP, you have to do something else to take the stone out. Then you have endoscopic ultrasound, which provides superior diagnostic imaging than even MRCP. Okay, and has an added advantage of facilitating biopsy and aspiration under guidance. So this is something that is mentioned in Dulanta Sir's Tooth. So it's better to know what it is. So this is just a summary that we came up with during the appointment. So we have you first do the ultrasound scan. If the ultrasound scan shows stones, you go ahead with the ERCP and stone extraction. If the ultrasound scan is suggestive of a carcinoma, then you will do a CT, a contrast enhanced CT. If you're unclear what it is and there's a possibility of stones still there, then you have to do an MRCP. So this is a treatment table that is given by Dr. Banagala. So I just included it here because it's a little easy to understand. So initially you have to, when you're treating, you have to do fluid balance. So correct dehydration, that is IV fluid. So monitor urine output needs to be done. Monitoring needs to be done as well. Then if there's any coagulopathies, you need to correct it. I will discuss this further, but this is, you need to correct any coagulopathies. And adequate nutrition also needs to be done. So specific treatments are if there is an emergency, that is if the patient is having features of cholangitis, you need to give them antibiotics. So IV cefuroxime 750 milligrams 8 hourly and IV metronidazole 500 milligrams 8 hourly. Then another emergency situation is unresolving gallstone pancreatitis. So you need to attend to that as well. So other procedures you can do, which is more of an elective procedure, is you can do ERCP with a sphincterotomy and stone extraction or destruction, that is a lithotripsy. Then you can insert a stent, that is for CVD stones that can't be removed easily. Then you have the PTC, that is again for stone extraction or even a stent insertion, which will allow the temporary drainage of the biliary system. Then CVD exploration not really done anymore because of complications. So don't really mention that unless you are asked. Okay. So these are again, we're going back to Dulanta Sir's lecture. So Polydocholithiasis management. So this is basically stone management. So ERCP plus sphincterotomy followed by stone extraction using either biliary balloons, Domia basket, stone crushing with a lithotripter. So you can temporarily stent as well if the stone can't be removed. Then PTC, stone extraction using a PTC guided techniques can be done. And surgery, you can do open or laparoscopic CBD exploration. Again, not commonly done. So mention the others first. So with the surgeries come with complications. Okay. Then we go to malignant obstructive jaundice. So here the surgical resection is possible in a certain group of patients with pancreatic carcinoma, periampular carcinoma, cholangiocarcinoma, and chronic pancreatitis. So the outcome is poor except if the patient has periampular carcinoma. So what you do is for malignant obstructive jaundice is basically you do a Whipple's procedure. So here you can see where you cut. So you basically cut around the ampular waters. That's where basically where the periampular carcinoma is. So you have cut number 1, which is here. Cut number 2, which is here above the gallbladder. Cut number 3, which is here. Okay. So there are 3 anastomosis that happens. A pancreatojejunostomy, which happens, that is pancreas to the jejunum. Hepatojejunostomy, where the bile enters, so the duct is connected directly to the jejunum. So the bile will directly enter the jejunum. And a duodenojejunostomy, that is, it restores the continuity of the GI tract. So the food will pass on the jejunum, through the jejunum from the stomach, preserving the pyloric function. So you don't necessarily need to know this in detail, just know what the procedure is that you do for periampular carcinoma. So if you have an inoperable tumor, you have to go for palliation. So palliation therapy here is in irresectable tumors. Endoscopic palliation with ERCP and stenting is done. So the stenting here is metal stents and plastic stents. So you can use either. So metal stent is kept for 6 months to a year, whereas plastic stents will have a shorter duration and easier to remove. Right? So this will relieve the symptoms. So like pruritus will be relieved. Otherwise, the patient's quality of life is hindered. So surgical palliation is you can do a double, triple bypass procedures and you can do cholecystojejunostomies. Okay, so one of the questions that was asked in the lecture is what are the management issues in a patient with obstructive jaundice undergoing an interventional procedure? So the main 3 problems are coagulopathy, hepatorenal syndrome, and risk of infection or cholangitis. So coagulopathy, this is due to vitamin K deficiency. So what do you do? So you have to check the PT-INR. So the INR target is it should be less than 1.5. So how can you treat a coagulopathy? It's oral IM vitamin K, IV vitamin K, or FFP. So oral IM vitamin K takes about 7 to 10 days. So if you have that kind of time and where you can correct it over 7 to 10 days, you can give oral or IM vitamin K. Then you come to more procedure-related correction. That is, now if you need to do an ERCP or some sort of procedure, IV vitamin K, that is onset is about 2 to 3 days. So if there is no significant bleeding and you can wait for about 2 to 3 days, then you can give IV vitamin K. However, if the procedure is the next day or you have an emergency like significant bleeding, then you have to give FFP. And you'll give about 4 units because this action will last for 24 hours. Then you have hepatorenal syndrome. That is, there will be decreased urine output. So like I said, you will give IV fluids and hydration, maintain the urine output, and you will give a vasoconstrictor, a splanchnic vasoconstrictor like terlipressin. Then you have risk of infection and cholangitis. So here you will actually give prophylactic antibiotics prior to doing the ERCP. So if there is a risk of infection, so you give IV cefuroxime 750 milligrams about 1 hour prior to ERCP. This is so that the maximum concentration is achieved when the potential of infection or contamination is at its highest. So why do you correct coagulopathy and how will you correct? So this is the same slide I've repeated here, but that's basically why the patients get the coagulopathy and how you correct it is mentioned here. So how will you prepare a patient for ERCP? Now, this is a question more relevant for your long case. If you get obstructive jaundice, so you need to tell the patient consultant this. So first of all, you need to get a date for the investigation and get informed written consent. Then you need to, now you're giving a contrast. So there are risks associated with the contrast medium. So you need to get a very good allergic history and exclude bronchial asthma. If the patient is a patient with bronchial asthma, you will start the patient on oral prednisolone or steroids, 10 milligrams TDS for 3 days. You need to also check the renal function test because again, you're giving contrast. So serum creatinine, serum electrolytes need to be checked. Good hydration must be maintained and you need to omit metformin before doing the ERCP if the patient is a diabetic. You admit the patient the day before the procedure. And due to the presence, the possibility of a sphincterotomy, you need to check the full blood count and TT-INR. Patient should be 6 hours fasting prior to the procedure. And you send the patient to the ERCP room after giving a cannula. Because remember, you can't expect them to do it. So these are little things that you can do in the ward. So the ERCP is done under sedation. So you have to give IV midazolam. But now when we were doing the appointment, as far as I remember, the patient was under GA. So when y'all are going for these classes, just ask this point from Dr. Dumindu, like what exactly you need to say, okay? So prophylactic antibiotics you need to give. So IV cefuroxime, IV metronidazole. And in the room, the patient will be in the left lateral position. You have to make sure there is oxygen via face mask. Monitor saturations and sedation with IV midazolam. So complications of ERCP, again, immediate, early and late. So immediately you can have perforation bleeding. Early complications are you can introduce an infection. So you can have cholangitis and acute pancreatitis. And late complications are strictures. Again, Dumindu sir doesn't consider this complication. So don't mention it unless they ask specifically. So here, these are some MCQs that Dumindu sir did in the lecture, which can come for the exam. So let's just go through these MCQs. Jaundice is clinically present when bilirubin rises over 1 milligram per DL. What do you all think the answer is? Does anyone want to give, like, even type the answer? No? Okay, so it's false, okay? So jaundice in sickle cell anemia is caused by an obstruction in the biliary canaliculi by deformed red cells. That's also false, okay? Pale stools is a pathogenetic feature in all cases of jaundice. Remember, this is not obstructive jaundice. So you can't say all cases. If it was obstructive, then yeah, but otherwise this is false. Pruritus occurs due to deposition of bile salts in the skin. That is true. Significant elevation of ALP is unlikely in hemolysis. That is also true because remember, it's significant to biliary obstruction. So it's false, 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 true, true. Then this is an SPR that has given also in the lecture. So a 75-year-old male presents with painless progressive obstructive jaundice of 3 months. His gallbladder is palpable, serum bilirubin is 12, and ALT levels are 1205. Ultrasound scan shows a dilated intra and extrahepatic biliary tree and a vague mass in the pancreatic head region. The most appropriate investigation is CT abdomen, upper GI endoscopy, ERCP, MRCP, PTC. So remember the chart I gave. So you have done your ultrasound scan. The history is suggestive of a of it not being a stone, because remember, it's painless, progressive, and the gallbladder is palpable. Okay. And the ultrasound scan shows a dilation of the intra and extrahepatic biliary tree and a vague mass in the pancreatic head region. So you're suspecting a carcinoma here. So your next step is to do a CT abdomen and pelvis. Okay. That's it. Give me a second. So that's all. I will send this presentation on the group. Do you all have any questions? Do you want me to repeat anything or anything like that? You can even type it and send. Okay, so that's it. I will log out now. I'll send this presentation on the group. Thank you. Oh, so sorry. All right. Okay. No worries. Thanks, guys. Bye.